Good morning, everybody. As usual, I see people are joining us. Hope you're having a good morning and staying out of the rain. Thank you for being with us today. We have a great special presentation from our own colleagues talking about the RECOVER trial, what we're excited to hear more about. Before that, we have a couple updates. I'll start with turning it over to Dr. Salas. Dr. Salas, as always, thank you for being with us.
Thanks so much, Dr. Asdalga. I just have two announcements. The first here is, again, just mentioning our culture and demographics survey, which is something that we've been working on with the Department of Pediatrics as a potential pilot for something that would be across the health system, potentially if all goes well. So this is really, we've put in a lot of time and effort into this to try to make it very thoughtful. And the idea is we want to understand who is in our departments and what your experiences are like so that we can make sure that we're best serving everyone who's here. The email will come out to you next Tuesday. So a week from yesterday, you should have gotten an email from the Department of Medicine chair account yesterday. And then it's also been in the newsletter if you're looking for more information about the survey. And then you will get an email on Tuesday, January 30th. It'll be coming from our DEI mailing list. So keep an eye out for that, which Helena just put it. Oh, sorry, she put it just for me. It's DOM DEI events at stanford.edu. Thank you, Helena, is the mailing list. So that's where the email will come from, again, next Tuesday. And it'll be open for a couple of weeks. It doesn't take more than 5 to 10 minutes max. So we really hope that you will take the time to do that. And if you have any questions about it, please contact me or Winona Alba, winona@stanford.edu, or that DOM DEI events email that Helena just mentioned. And I will, I think I'll just put it in the chat as well, so everyone has that, especially for folks who are more visual. Next slide, please. Oh, thanks so much, Helena, for doing that. We are so excited about another excellent Black History Month coming up. These are the speakers we're going to have. So Dr. Chris Flowers will be here on February 7th in person. So we hope to see everyone there or virtually if that's what works best for you. But this will be a fantastic talk kicking off the month. And then we also have Dr. La Princess Brewer, who is a cardiologist, our own Dr. Robert Fairchild, and Kimani Paul-Emile, who is a lawyer who studies health disparities. So again, another exciting month of Grand Rounds for us, and we hope you'll be able to join us for as many of these talks as possible. I'll turn it back over to you, Dr. Asdalga.
Thank you, Dr. Salas. Yes, looking forward to seeing many of you in person in a couple of weeks to kick off February. Before then, though, we have another one of our own presenters, Dr. Alana Yurkowitz, who are presenting Fragmented, a doctor's quest to piece together American healthcare and write a book on it. So that's the title of her book. You can find it on Amazon. It's also on Kindle and Amazon Audible as well. She's going to be presenting on, I imagine, much of what she talks about in the book. So please check out the book, but also join us next week to hear her present on it. It will be on Zoom as well. With that being said, before we introduce our new presenters, I want to thank Dr. PJ Utz for being here to introduce our presenters today, Dr. Singh and Geng. So thanks so much, Dr. Utz. I'll turn it over to you.
Great, thanks so much. And this is what we're hoping will be a series of talks that we're going to have, hopefully quarterly, on Department of Medicine team programs and especially projects that have been really successful and show us what we can do with team science. So it gives me great pleasure to introduce Dr. Linda Geng and Upi Singh. I've spent more time with these two professors in the Department of Medicine in the last year than anyone by far on the projects that they're going to describe today. Dr. Geng is a clinical associate professor of medicine in the division of care of patients with puzzling and complex conditions. Dr. Hector Bonilla, she has started a multidisciplinary law COVID clinic and research program. She earned her bachelor's degrees at Rice University, and 2 degrees, and then a PhD at University of Washington, a 1-year postdoctoral fellowship at UT Southwestern, and she did a chief residency. Sorry, it sounds like maybe breaking up, so I apologize. Residency, chief residency, and now she's an associate professor. Yeah, sorry, it sounds like I'm breaking up. Is that right?
Yeah, PJ, we can hear you a little bit, but it is broken up a little bit.
Yeah, I must be having some audio problems. I don't know if it's because of the storm. I can try to go off
So,
video.
yeah, maybe try that, but it's a little bit better towards the end there.
Okay, how's this?
I think, yeah, go ahead.
So I got this. Dr. and I'll be brief. Dr. Singh earned her bachelor's degree and her MD from Ohio State, and then did residency and fellowship at the University of Virginia. She is then did her assistant professor, associate professor, full professor of physicians here at Stanford. She's been here for almost 25 years now. And so Dr. Singh and Dr. Geng are going to tell us about their work in long COVID and a Paxlovid study and a recent government-funded program that they just received funding for. So let me turn it over to Drs. Geng and Singh.
Thanks so much, PJ, and everyone. Good morning. Happy New Year. I'm going to have Dr. Geng start our slides. I want to thank everybody for joining us. Dr. Geng and I are excited to present the work. I want to start by saying, and we will definitely acknowledge everybody who's led and been involved in the work, but I just want to start by saying, again, this is a team science project. Linda and I are privileged to present the work to you, but really it is very much a group effort. And hopefully you'll agree that a group success. So we're going to talk about the program that we have on long COVID. Here's a list of our disclosures, including advisory committees and research funding. And I do want to mention at the bottom, the Stop Pass trial that we'll talk about is funded by and conducted in research collaboration with Pfizer. And there's a digital wearable sub-study. So on this slide, we're going to talk about the outline of the talk. We're going to talk about what is long COVID, both the definition, pathophysiology, the impact and treatment, and then our experience at Stanford with the disease, ways in which we're trying to identify ways to treat long COVID, a little bit about the clinical program, and then some more recent efforts that we're very excited about community outreach and education. So I want to mention up front that as we talk about the definition, pathophysiology, I have this outlined in yellow because we will talk about this, but I just want to say at the very beginning, there's no specific lab diagnostic test or biomarker at this point to diagnose the illness or follow disease progression. And the pathophysiology is unfortunately still not fully defined. There's definitely a lot of intriguing results and the disease is evolving. And so those two things, the definition and pathophysiology, do make a lot of the work around clinical trials and other things challenging. So we're going to talk to you about both the opportunities as well as the challenges that we've had. In terms of impact, we know that there's substantial impact at both the individual and societal levels. We'll show you some data. And current treatment is supportive care. There's no disease-specific treatments available at present, unfortunately. Next slide. So the definition of long COVID, I think many of you know, but there's multiple names that are associated with it. It's been called long COVID, long haul COVID, or post-acute sequelae of SARS-CoV-2 infection, or PASC. This disease is defined broadly as signs and symptoms and conditions that continue or develop after an initial COVID-19 infection. Different organizations define it slightly differently, but it's really signs, symptoms, and conditions that are present for at least 4 weeks or more after the initial phase of COVID-19. The symptoms can be multisystemic, and more than 200 symptoms have been identified. Those symptoms that are present with long COVID may or may not have been the symptoms present during the acute COVID infection. The symptoms can be relapsing, remitting, and they can progress or worsen over time. So the fact that it's multisystemic, the fact that the symptoms come and go really do make this difficult for patients and often providers to identify. Next slide. When I talk about clinical symptoms of long COVID, I always sort of talk about it as a disease that's from head to toe. So there can be everything from neurologic issues of cognitive impairment, fatigue, issues of memory loss. There can be pulmonary issues of cough, dyspnea, cardiac issues of chest pain, palpitations, GI issues, and then all the way down to issues with blood vessels, coagulopathy, et cetera. So really a very broad range of symptoms indicating probably a broad pathophysiology that's causing these. Next slide. This is a really nice review. I don't know if you can see this, but at the bottom we've listed the link. It's a nice review by Dr. Topol, looking at some of the hypothesized mechanisms of long COVID. So these include immune dysregulation with either reactivation of viruses or persistent infection, microbiota dysbiosis with impacts of SARS-CoV-2 on both the microbiota as well as the virome, including potential SARS-CoV-2 persistence, autoimmunity and immune priming from molecular mimicry, microvascular issues with blood clotting and endothelial dysfunction, and then also some dysfunctional neurological signaling. So again, a broad range of hypotheses that are being tested around the country and around the world. Next slide. In terms of impact, this is data from May of 2022, and the American Academy of Physical Medicine and Rehab at that time estimated that there had been about 80 million people who were surviving SARS-CoV-2 infection in the United States, with an estimated incidence of long COVID or PASC at that time of about 24 million. So this is back in May of 22, and more recent data shown on the next slide. This is looking at the U.S. Census Bureau, looking at individuals who've ever experienced long COVID as a percentage of all adults, looking at a national estimate, and starting in June of 22 all the way to October of 23. And you can see, according to them, it's about 14% or so of all adults have ever experienced long COVID or long COVID symptoms. On the next slide, we'll look at similar data, but looking at those who are currently experiencing long COVID as a percentage of adults. And here the numbers are going down a little bit, maybe to about 5 or 6%. It's not clear if that's because people have sort of accepted their symptoms and no longer identify those as long COVID, or if in fact this reflects part of the natural history of the disease, which is that in some individuals, symptoms do abate over time. Next slide. Although today we're going to talk about post-acute sequelae of SARS-CoV-2 or long COVID, this is a nice review from Akiko Osaki that talks about broader issues. In fact, there's a number of other unexplained post-infection syndromes, including from things like as chikungunya, EBV, dengue, polio, and flu. And so although specific examples of what we can learn from PASC may not be identified, there are, in fact, other syndromes of fibromyalgia or ME/CFS, for example, that are very syndromically similar. And so I think the 30,000-foot view is that we're hoping that some of what we learn about SARS-CoV-2 and long COVID will, in fact, be applicable to other illnesses that are affecting a lot of individuals. So we're going to talk about some of our recent efforts to identify ways to now treat long COVID. Next slide. This is the slide I showed earlier about the different hypothesized mechanisms, and I mentioned that there's some hypothesis and some data indicating that there may be viral persistence. And so this is the angle that we're going to take for the first trial that we're going to talk about. So our trial is called Selective Trial of Paxlovid, or PASC, or the STOP PASC trial. It's a phase 2 randomized double-blind placebo-controlled signal-seeking trial. I've listed the ct.gov number. The question here is really this: can an antiviral that's active against SARS-CoV-2 virus decrease the symptoms of long COVID? So we're not talking about treating people during acute COVID here. We're talking about once somebody has established long COVID, can we give them an antiviral that we know is active against SARS-CoV-2 and then see if their symptoms go decrease? As I mentioned, viral persistence is a leading hypothesis, and viral persistence has been noted in, for example, immunocompromised individuals. It's been seen in multiple organs and autopsy studies, and then in other studies, it's been seen in the GI tract, including in stool and biopsy specimens. So the antiviral that we chose to use first is Paxlovid, which many of you are familiar with. This is nirmatrelvir-ritonavir combination. We know that it's active against SARS-CoV-2, and we know that using multiple clinical trials, that treatment of high-risk individuals during acute COVID prevents hospitalization and death. And so those data are the ones that gave this drug EUA and approval for treatment during long COVID. And then there's also some intriguing data from retrospective EHR analyses that treatment during acute COVID may reduce subsequent development of long COVID. And so based on these data, based on the hypothesis and data around viral persistence, we chose to study this drug. We were the first study in the world to use Paxlovid for the treatment of long COVID. Subsequent studies are now I'm sorry, I can't see the bottom of the slide, but subsequent studies are now also underway at Yale, at Karolinska, and then within the NIH Recover program. Next slide. As I mentioned, there's no biomarkers and no way to necessarily follow the disease. So there's a number of design challenges, and I think it's helpful to sort of think through this. I want to take you back to August of 22. That's actually when we developed the protocol. And at that time, there was no precedence in the literature for studies on long COVID, and there was no specific guidance from the FDA. Specific challenges included no biomarkers to stratify inclusion, no validated clinical or biomarker endpoints, and really multiple clinical presentations. As I mentioned, this is a disease that can be from the head to the toe. It really wasn't clear to us, and I think still isn't clear to us, whether all these different manifestations are the same disease or whether there's subsets of diseases and illnesses. When you sort of are breaking ground and trying new things, you move forward despite some uncertainties. And so we move forward with this protocol, got FDA approval to do the study, and enrolled our first participant in November of 22. Here's a little bit about the objectives of the STOP-PASC trial. The primary objective is to compare the safety and efficacy of 15-day course of Paxlovid versus placebo in reducing symptom severity in participants with PASC. I want to point out it's 15 days of Paxlovid, not the typical 5 days that's used for acute COVID. And here we wanted to use the longest possible duration of treatment that we could, with the idea that if there's persistent virus, it may take longer to treat long COVID. The secondary objectives were to compare overall symptom burden of participants with PASC treated with Paxlovid versus those treated with placebo, and then to evaluate other patient-reported outcomes, for example, functional or global status, and those treated with Paxlovid versus placebo. And then if there are, in fact, symptoms that respond to Paxlovid, identify whether there's some core symptoms that are more responsive to the drug than not. We have a number of exploratory objectives to investigate potential biomarkers of PASC in participants treated with Paxlovid versus placebo, and then to investigate potential digital biometric markers of PASC severity and correlate those with intervention outcomes. So here are the inclusion and exclusion criteria. It's a lot of info, but I just want to focus on those things in red on the left side. In the inclusion criteria, we wanted individuals who had a confirmed index COVID-19 infection. We recognize that not everybody will have that, but again, in a small signal-seeking phase 2 study, we felt that we needed to start with this criteria. We included individuals who had symptoms for more than 3 months of PASC. And again, this is to identify individuals who sort of have some stable symptom complex. We looked for people who had 2 or more core symptoms, and we defined 6 core symptoms of fatigue, brain fog, dyspnea, body aches, cardiovascular symptoms, or GI symptoms. And we looked for individuals who had a severity of core symptoms that is at least moderate or severe. So on a Likert scale of 0 to 3, individuals who have either a symptom severity of 2 or 3. And then the other inclusion and exclusion criteria are listed here. So the next slide will show the study design. This is a complex slide, so let me start from the top and take you down. So as I mentioned earlier, it's a 15-day treatment period and then a follow-up for a total of 15 weeks. We looked for adults with PASC, looked for about 200 individuals, randomized them 2 to 1. So individuals got nirmatrelvir ritonavir or Paxlovid or placebo ritonavir. I want to mention that we had to use ritonavir in the placebo arm as well, because for those of you who've taken Paxlovid, there's a bad taste in your mouth, and that's due to the ritonavir. And we were concerned that if we didn't have a placebo arm with ritonavir, that people would unblind themselves, or we would get unblinded to their assignment. The primary endpoint was at week 10. We were looking to see if people's symptoms improved, and then if there was a durability of response. And then the study was a total of 15 weeks. Under screening, we have those stethoscopes to show all the visits that are in person. So we had 5 in-person visits from these individuals. And then on the left-hand side are the different things. So they did symptom surveys weekly, and then every 2 weeks. There were patient-reported outcomes, PGIS, PGIC, and PROMIS surveys, a few very discrete clinical assessments, and then sample collection. And as you'll see, we focused a lot on blood, nasopharyngeal stool. We wanted to have a robust group of biomarkers. And I'm sorry that the bottom is cutting off. The bottom says, Linda, I think if you move the pointer off this screen, it might show up. But the bottom says a digital wearable study, which was offered to those individuals who wanted to join. It was a sub-study, and was offered to those who were able to join. Next slide. So here's a randomization and subgroup analyses. We did 2-to-1 Paxlovid versus placebo. We stratified by vaccination status and the number of baseline symptoms, so either 2 to 3 or greater than 3. And we did a number of different subgroup analyses. We also had a lot of exploratory endpoints. A lot of them are going to be based on those biosamples that we collected. So biomarkers such as D-dimer, SARS-CoV-2 RNA, RT-PCR in the stool, and then changed from baseline in Paxlovid versus placebo of a number of different features such as cytokine, autoantibodies, RNA-seq, and immunophenotypes. And then the digital sub-study was for those who had iPhones and looked at all features such as physical activity, heart rate, and variability, ECG, O2 sats, and blood pressure. There were a number of operational considerations, and I think, as I mentioned, we were the first people in the world to start the study. There's certainly a lot of opportunities, but then some significant challenges. I think it's helpful to think through this. There were a lot of opportunities, and I think the biggest few were that there was significant patient interest and motivation. So a lot of people are suffering. Everybody knows somebody who has had some long COVID symptoms, and so a lot of interest and motivation in the community. It is a signal-seeking study, and so with biomarkers and wearables, we feel that it'll add to our understanding of long COVID and its disease trajectory and natural history, independent of any clinical outcome. So we felt that there was a lot of great science that could be done. However, there were a number of challenges. One is that the drug-drug interactions with Paxlovid are complex, as those of you who've ever tried to use it or prescribe it. And so we had to work through the risks very carefully. We, of course, wanted to do no harm. So there was a significant and labor-intensive screening process. Many individuals with long COVID are taking many medications and supplements, and so we had to work through those safely. And so we had multiple layers of both physician, RN, and pharmacy checks for drug-drug interaction checks. There were many individuals from early in the pandemic who didn't have documented testing, and so there was certainly community frustration, and we heard from a number of individuals who were unhappy with our decision to choose that as a enrollment criteria. And then during the 15 weeks, people, had got vaccinated for other things or had COVID reinfections, and those were certainly some operational challenges for us to consider. We learned a lot of lessons, which is sort of what we aim for with all science. One is that long COVID patients with multiple issues, it was tough for some of them to participate fully in the trial. As I mentioned, it's 5 in-person visits, a lot of daily symptom surveys, et cetera. So the study burden and cognitive burden wasn't trivial for some individuals, and certainly the wearables and medication management was challenging for some people. We had to manage some medication changes to avoid DDIs. That was complex for people. And certainly the study burden on staff was much higher than expected. As I mentioned, it's quite labor-intensive study. But the progress to date is listed here. We had a DSMB review that found no safety concerns. Our last patient last visit has been completed. Today, what we'll do is share some initial safety and cohort characteristics, and we hope to be able to share the final results very soon. So here's a concert diagram of our experience. So we had 784 individuals from the general community as well as long COVID clinic that expressed interest. 616 were excluded as listed there. 168 were consented and screened, and 155 were randomized. We assigned 2-to-1 nirmatrelvir-ritonavir versus placebo-ritonavir as shown there. At the end, we had 4 individuals from each arm that withdrew. So overall, we had really good retention, really good compliance. And at the end, we were able to analyze 53 in the placebo-ritonavir versus 102 in the Paxlovid arm. Here are some characteristics of the 2 arms. The age was a median of 44. You can see the gender distribution as well as the race distribution. I think we all know, and I'm sorry if the bottom is not showing up, but the Hispanic population, we all know, was affected more by COVID and potentially also long COVID. And so we had about 11% of Hispanic population in our study. We were happy for that. Would like it to be more with the next event. Next slide. The BMI is listed there, as well as the different categories and the two arms. I want to point out the duration of symptoms. So people in our study had a mean duration of symptoms of 536 days with the standard deviation that's shown there. So these are individuals who had, not surprising for a first study on long COVID, had substantial symptoms for a long period of time. The index infection date is shown there. After December to 2021 is about 42%. So that means that about 42% of people who enrolled in the study were in the Omicron area or after. And then the other individuals were those before the study. Next slide. This is listing whether, the number of infections they had, whether they were hospitalized or not. I want to focus on the hospitalized for the initial COVID-19 infection. And you can see here that only about 6% of individuals in both arms were hospitalized. We think this is a really important characteristic. What this tells us is that, about 94% of individuals in our study had mild or moderate COVID. They didn't need to be hospitalized. And that's actually the majority of us, right? And the majority of the world. And so results that we identify, biomarkers that we identify, we think is actually more representative of a general broader population rather than focusing on people who were, severely ill or in the ICU. So we think that's a strength of our study. We've listed there whether people got SARS-CoV-2 medication for their acute infection, and you can see that the majority didn't. We used vaccination status at randomization, but as it turned out, only one person from both arms, from each arm, wasn't vaccinated. And then we looked at the number of moderate or severe symptoms, 2 or 3 moderate or severe symptoms, or more than 3, and you can see the spread of it, individuals. Next slide. I just want to remind people that the study, you had to have at least 2 of these 6 core symptoms. Fatigue, brain fog, dyspnea, body aches, cardiovascular, and GI. Some of you may ask why we picked those. Again, that was a point of a lot of discussion and thought, and we can go into that later. But we picked them because these were the most common symptoms that have been reported in many long COVID studies, as well as what we've noticed. It doesn't mean these are the only symptoms, but these were the ones we picked. And then, as you remember, the severity of the core symptoms has to be moderate or severe. And again, this was picked for individuals. So if we saw a change as an improvement, we would be able to identify that. Next slide. So here's the core symptoms at baseline. Each of the 6 core symptoms is listed there. The nirmatrelvir-ritonavir arm versus placebo-ritonavir is shown. And on the bottom axis is the percent of individuals who had the different symptoms. And you can see we have in green are people who have no symptoms. So you can see that the 2 most common symptoms in these individuals were fatigue and brain fog. And almost everybody had fatigue, and a very large portion of people had brain fog, including in severe, which is shown in red, or in moderate, which is in orange. So, 90% of people had fatigue and brain fog of moderate or severe, and another, I can't see the axis, but, like 80 or 90% of people had severe or moderate brain fog. You can see that body aches and cardiovascular issues were less common, and then shortness of breath and GI symptoms were the least common. But even in those 2, a significant portion of individuals had severe or moderate symptoms. In the next slide, we wanted to show you some safety analyses. Of course, this is important. We know that 5 days of Paxlovid is safe and can be given for people with acute COVID, but these are complex patients with lots of other comorbidities potentially, and we wanted to see whether 15 days of Paxlovid could be given safely. And in fact, we found that it can. The serious adverse events are listed here. There were 4 participants in the study, 3 in the Paxlovid arm, 1 in the placebo-ritonavir. 3 of those events connected to hospitalizations, and we think were not related. There was 1 event of hepatitis that we identified as possibly related to placebo-ritonavir, and these are known side effects. Next arm. Next slide. So some key findings, we found that the Stop Pass trial demonstrated the feasibility of implementing a complex protocol with a high level of patient engagement and retention in this complex patient population. We identified the 15 days of nirmatrelvir demonstrated an overall favorable safety profile in this patient population. The clinical efficacy analyses are underway, and we hope to share those soon. But we also feel that we obtained a very rich clinical data set for multidimensional integration with exploratory data such as biomarkers and digital wearable study. I'll turn it over to Dr. Geng for the rest of the talk.
Great. Thank you so much, Dr. Singh. So I'm really excited. As Dr. Singh was saying, this is, we're just representing our whole entire team science effort and team effort. And so I just want to make sure that we give also recognition to the entire group. And my next slide is actually going to be emphasizing the fact that clinical care, but also the research that we do is really requiring multidisciplinary collaboration and partnership. And we're so lucky to be part of the collective village that's helping to tackle a very, very challenging problem. And so I just wanted to remind folks, Dr. Bani and I think a while back had given a presentation about our clinical program as well. And we are, again, so lucky to have a large group of experts and clinicians who are working with us to care for patients with long COVID. And our current clinical care model for the PACS clinic, which stands for post-acute COVID-19 syndrome, but as you know, there's a lot of different names for this, involves a hub and spokes model, where in the hub or the portal where patients enter through the clinic get referred from internal or external referrals, and they see one of us in the hub, including ourselves and myself, Dr. Bania, my co-director, and Dr. Schaefer, and our NP and APPs, and in internal medicine as well as infectious diseases for a comprehensive and standardized evaluation. And many people present in many different ways. And it's important, because we don't have a biomarker or an objective test, that we must also be comprehensive in thinking and partnering with the PCP to understand what else might be going on or contributing to a very complex set of symptomatology. Additionally, this is integrated with research efforts from our entire multidisciplinary group, as well as a lot of the other projects that we talked about. And depending on an individual's needs, which can be very different, they may further then be referred to our the spokes, which are the subspecialty or specialty care from our wonderful multidisciplinary group across departments and across divisions. And we're really lucky to have some world-leading expertise, especially in autonomic neurology, cardiology, pulmonology, ME/CFS with Dr. Bania's team, and so on and so forth, and in some of the very specialized expertise as well in other departments. And so with that, we're thinking and unfortunately, like with this, as well as other clinics around the country, there's such a demand, but limited capacity. And that results in delays in care. And part of the question is, how can we also improve upon this? And some of the findings from our clinic, with the help of our research students and collaborators, include some of these findings. So that our outpatient clinic sees a lot of outpatient patients who presented who were not hospitalized. And this is in contrast to some other long COVID clinics who were designed originally or originated because they were following ICU follow-ups and hospitalization discharges. So we had a relatively at baseline healthy population. In our patient cohort, about nearly half meet the diagnostic criteria for ME/CFS or myalgic encephalomyelitis, chronic fatigue syndrome. And again, speaking to the fact that there's overlap in these syndromes, and we're still trying to understand and tease apart what are the overlap features, the underlying biological mechanisms that might tie these phenotypes together. In addition, interestingly, a drug called low-dose naltrexone, which is low doses of the drug naltrexone that's been around for decades, has been used in conditions such as ME/CFS and other autoimmune diseases, fibromyalgia, and it is an anti-inflammatory agent that's been studied in some of these other conditions, these related phenotypes, these overlap syndromes. And we leveraged that knowledge in addition to its safety and generic availability to see if we can use it as an off-label therapy for those who meet that phenotypic criteria. And we found that indeed, there seems to be, at least in this retrospective, self-reported subjective symptom reporting, and that there seems to be signals that suggest that LDN could be a reasonable candidate, just as it was for ME/CFS and fibromyalgia and some of the other autoimmune diseases, that it could potentially be leveraged for long COVID as well, particularly for total burden of symptoms, fatigue, and brain fog, and some of the classic ME/CFS type symptoms. It needs to be studied rigorously in a randomized clinical trial, and there is one that is posted and should be launched from UBC in Canada, and we look forward to seeing the results of that. Additionally, some of the other interesting findings that we've noted from observing and learning from our patients include that some patients, a pretty significant subset of long COVID patients, develop new onset intolerances or sensitivity to alcohol. In fact, there's oftentimes a report from patients that they have new onset sensitivities to a lot of different things, including medications and environmental agents, foods, etc. It seems like there's just a heightened sensitivity and reactivity in general, but in particular, we've noted this alcohol sensitivity or intolerance. We're not exactly, the manifestation of this can be variable. Some people, they can feel intoxicated at a much lower level than they did pre-COVID, or they can have the worst sort of hangover effects, or they can have worsening of their long COVID symptoms, and they feel extremely debilitated with exhaustion, fatigue, headache, and other symptoms. We think that this is an interesting phenomenon that should be studied further and observed and also assayed in a larger population and studied at a mechanistic level, because perhaps it actually reflects an underlying mechanism, whether it's related to inflammation or integrity of the blood-brain barrier. And so this is something that we think is important from a mechanistic standpoint, but also if patients are aware of this and clinicians are aware, we can also do a better job of screening and have management implications in lifestyle modifications of exacerbating factors. Long COVID and COVID vaccines are also a really important point of discussion. One of the most common questions that we get in our clinic is, with my long COVID, should I be getting a booster shot? Should I be getting a COVID vaccination? And although there's actually a really robust growing body of evidence to suggest that COVID vaccination has protective benefits against long COVID, against developing long COVID, there's a paucity of data regarding those who already have long COVID and what are the effects of vaccination on that. So we are trying to generate self-reported symptomatology that patients have reported to us regarding when they get their boosters, what are they experiencing, and hope that this will help to generate hypotheses and have further prospective studies as well on this. And what we found so far is that some patients report feeling better. In fact, there are some people who feel many of their symptoms were cured because of boosters and vaccinations. There is a small subset who feel worse and worsening of their long COVID symptoms after COVID vaccination. Most of the people, the majority of people, don't report in their retrospective recall feeling any different in terms of their long COVID symptoms. So the chances are that if somebody were to get a booster, at least per patient's subjective self-reporting, that they're not having changes in their long COVID trajectory. But this warrants much further and deeper study and trying to understand the relationships between a vaccination, which of course have a lot of benefit and public health importance, but also understanding the mechanism of it. And in our clinic, we also hear about patients who actually they recovered from their COVID vaccinations, but their symptoms had started after, at least in correlation in time, not necessarily saying causation, but around the time of vaccination. So we think that the immune system studies and biological underpinnings are really important to understand some of this overlap, but also potential great benefit for a subset of patients where it could potentially be even curative. And so next, I'm going to talk about our efforts at community outreach and education. I alluded to this earlier that we're really excited about our program. We learn so much from our patients, but unfortunately, from a logistical standpoint, and this is not unique to us, but there are often long waiting lists to get into care for long COVID. And so how do we solve this problem? And this is a federally recognized issue of how can we care for more patients with long COVID, better reach vulnerable communities, and support primary care. And because, primary care and all physicians are going to be seeing the millions of patients, are seeing the millions of patients who have long COVID or suffering from sequelae from COVID. And so we're really lucky. We are part of the 9 multidisciplinary long COVID clinics that have received federal funding from the Health and Human Services through the Agency for Healthcare Research and Quality, thanks to the support of the team science effort with my counsel, Nancy Lonhard, in submitting our grant application with our team science efforts. And so the goal of this and the objective outcomes that we're going to be trying to measure from our care delivery models are to develop and implement new and improved care delivery models, provide services to more people, reach more people, in particular, vulnerable patient populations who've been disproportionately impacted by the pandemic, expand the services, strengthen care coordination, because again, this is a very complex condition with many multidisciplinary efforts, and share best practices. The field of long COVID, the knowledge is nascent and we're constantly evolving. There's new papers coming out every day. And right now, I would say that even the idea of best practice is still evolving. There's not a lot of evidence to guide us in terms of clinical care. And so we need to generate the evidence at the same time that we're rapidly able to disseminate that evidence and best practices for long COVID management. And we need to support and empower, and this is my home, but primary care and primary care clinicians, especially those out in the community serving the underserved and in long COVID education, providing them tools to be able to manage so that we can serve patients where they are with clinicians they trust, and for those who need it, potentially come to a quaternary or tertiary center for a specialized care. And then, of course, we need to evaluate, are the strategies and approaches that we do successful, and disseminate the project findings and hopefully be able to change policy as well. And so the way that we are approaching this from Stanford is we think that in order to reach the community, we have to have community partnership. And we're so lucky to have this incredible community network that we're building relationships with and maintaining relationships to be able to really, be able to disseminate as well as deliver the care, especially to the community and vulnerable patient populations. And so we have 2 care delivery partners who are also sub-awardees on this sponsored grant. And that's through San Mateo Medical Center, and Dr. Vivian Levy is our partner site PI there, whom we've also collaborated with and has worked with us on other projects. And Community Health Center Network, a really incredible large network of federally qualified healthcare clinics across multiple different counties and 8 different and multiple different healthcare centers with several different clinics, and collectively serving many diverse populations around the Bay Area region and beyond. And Dr. Trudeau is a partner site PI who we're really lucky to be able to work with, and their team at both of these sites, as well as partnership with the Santa Clara Public Health Department and other public health departments, community-based organizations, nonprofits, especially for outreach, as well as resources for those who are disabled or need work or school accommodations, and also other healthcare centers who have links with Stanford as well, Roots Family Community Health Center, as well as a large California Primary Care Association, where they encompass an entire network of all the different community health centers and FQHCs in California, serving about 1 in 8 Californians. And we're really excited to leverage the expertise, the insights and wisdom, and the stakeholder input and co-design with all our community partners to be able to reach a larger and broader and more diverse patient population and raise awareness as well. And so with this, I feel so lucky to be able to co-lead this with our other principal investigators, Dr. Hector Benia and Dr. Upi Singh. And we are excited also. I just want to give kudos to Marissa Marapal, who is an incredible program coordinator, providing the glue to all this. But as you can see, this, I hope that this demonstrates it's really a team effort. It's really team science. And working with and collaborating with Dr. Steve Ash and Marcy Winget's team at ESU, as well as Dr. Ruth Adewiya and her team at CME, our incredible multidisciplinary clinicians, as I mentioned, across departments and divisions, our incredible staff and leadership team at SHC and analytics, as well as Dr. Lisa Goldman-Rosa's team at OCE and the Community Engagement Office, and our external partners that I mentioned before, but also importantly, a community advisory board with voices from patients, as well as a diverse patient representation, as well as family members and other advocates as well. And we are also, I want to emphasize that this is a U-type grant where the cooperative learning and kind of collaboration with the sponsor, as well as the what we call the national learning community with 8 other grantee teams, will be so important to learn at the national level. What works? How do we harmonize efforts? How do we, synergize in education? And this is really an exciting endeavor where we hope to make big changes, not only in our regions, but at a national level with our collaborators and our partners and peers. And so the way that our model is trying to innovate and think about how we can deliver better care is we think about reach. Ultimately, we're trying to expand long COVID care. And so we have 3 aims that are tiered in nature. And the first tier, our first aim, is really aimed at if you have the foundations of knowledge and education and awareness, because you can't diagnose if people aren't aware, especially in hard to reach communities who may not even be aware that there's such a thing as long COVID. And so that's one of the first aims. But in parallel, you need to build the capacity as you're educating and raising awareness. And at the bottom of the pyramid, there's the highest reach, where you have the awareness and outreach and education. And then lower touch, because at the highest level, you're having direct patient to provider contact. And then in the middle, we have aim 2, which is our partnership with San Mateo Medical Center and with Community Health Center Network, where we have the FQHC care delivery partnerships. And here our goal is to do peer-to-peer, to be able to, instead of bringing the patients to Stanford necessarily, we need to bring Stanford expertise out to the community and meet the patients where they are with clinicians that they trust. And other models have successfully been able to demonstrate this in hard to reach areas like rural areas and underserved populations through models like ECHO and other telementoring type approaches. And so that's the type of approach we're going to have as well with our FQHC delivery partnerships. But our aim 3 will also be to grow our Stanford Hub program and support the capacity, not just to grow in total, but particularly to grow for underserved patients and to be able to provide resources to support their care and reduce their barriers. That includes, for example, patient-facing or patient-directed strategies, in addition to educational resources, helping to have a navigator or care coordinator, because it's really complex as they're trying to navigate not only within Stanford, but outside of Stanford, multiple clinics and multiple visits, referrals, testing, et cetera. And the social worker to be able to reduce transportation and other social determinants of health needs, as well as for mental health resources and support, and other connection to resources in the community, such as for workplace accommodations and other resources, and care expansion as well for different types of services that can be provided. And then for the provider-facing or directed strategies, we have the proposed ideas of clinical toolkits where, the things that we use, for example, templates and other resources, we want to be able to provide that to the community clinician so that they are empowered and equipped to then be able to start to think about, how do I deliver care? How do I start to evaluate a patient who might have long COVID? How do I screen for a patient with long COVID or suspected long COVID? And do with our multidisciplinary expertise team a webinar series, a CME educational program to really start to be able to get to details about case-based learning and concepts that are rapidly evolving in both the pathology as well as evidence-based practices. And then we want to be able to develop a Q&A platform similar to an e-consult, but one where there's not going to be identifiable patient information, but a platform that will allow clinicians to ask questions to our specialty team that then can build a knowledge base and start to be accessible as frequently asked questions, so that any clinicians can start to learn from what others have asked as well, and start to feel more empowered about the knowledge base that they are able to access. And as I mentioned and alluded to before, the ECHO-like telementory case conferences where community clinicians can come to us, and it'll be peer-to-peer learning. I think there's lots we can learn from our community clinicians, and similarly, being able to do a bidirectional exchange of knowledge and expertise will really, I think, be beneficial. But that is to be evaluated. And so we're really excited to put forth this model. And it'll be an iterative one because we're also harmonizing and trying to assess data elements to evaluate outcomes across the 9 institutions. And so we're really excited to see where this will lead and continue to reevaluate as we go along with this 5-year project. What we hope to do, this is just trying to summarize then, it's a busy slide, but I want to emphasize here what we hope to do at the before and the after that we're hoping to achieve. And summarizing here again, some of the barriers, there are many, many barriers to comprehensive person-centered care, especially for vulnerable patient populations. There is an underdiagnosis. We've just in our listening tour in the community health programs, there's an interesting kind of phenomenon where, based on some of the publications as well as what you see with, epidemiologic data, you would suppose that there will actually be higher rates of long COVID out in the community, but especially in safety net clinics. But what we have heard is that there doesn't seem to, or at least not reported to be as many cases. We're going to gather baseline data very soon and be able to report out on that. But there is a discrepancy to expectations and what we observe. And so why is that? Is there an underdiagnosis and a lack of awareness or, other barriers to consider as well? And lack of support or lack of ability to, consider appropriate referrals, as well as, limited capacity at all levels for care, and then limited social services as well, especially to support the most vulnerable patient populations. And our strategies, as I mentioned before, include education, peer-to-peer support, and capacity expansion. What we hope to do is that in this large kind of care model and network where we have the Stanford hub as well as our safety net FQHCs across the 6-county region, we hope to increase those who are diagnosed and those who are reaching care. And many of them can be reaching care at their primary care level, but we also hope that, of course, we're also expanding for those who need that higher level of care at the more subspecialized care level at Stanford Hub as well, and supporting them at both levels as well. And so finally, I just want to, again, thank so much the team science support for all this, as well as just reflecting the team science that goes into this, the Stanford Stop Pass team, as well as our collaborators at Pfizer AI Care, and our clinical program, our staff, and our incredible experts and the multidisciplinary clinicians, and our U18 long COVID care REACH. The program is called REACH, and the ESU team, the CME team, and all of our collaborators, and also our research students, and importantly, our community partners, our patients, and the caregivers from whom we're constantly and actively learning from and partnering with to tackle this big challenge. So thank you all very much.
Thank you, Dr. Geng and Singh. That was excellent. We are definitely looking forward to the clinical efficacy data. Dr. Singh, and we're happy to, we'll certainly send out this video in the next day or two once it's ready, but we're also happy to resend out this video when the clinical data is available to do another press release to everybody. I know people are going to be messaging us asking if it's available yet. So, and I know a lot of people from a clinical standpoint, research standpoint, patient standpoint are interested to hear it. So thanks for presenting. We do have a number of questions. I'll get into it now. And Dr. Utz, please hop in the conversation anytime. Again, thanks for being with us. Thomas Burns asked, why did you decide to prescribe Paxlovid for 2 weeks? I know also, Dr. Singh, you had answered Dr. Parsonet's question about did they both get Paxlovid? I think 17% on each arm as well. Any comments on that in general?
Yeah, so as I mentioned, acute COVID is 5 days. We, at that time in October of 22, we wanted to use the longest possible duration. So at that time, based on sort of input from FDA as well as Pfizer, it was felt that 15 days was where they had the greatest amount of safety and human safety and other data. There is a study now. We would have liked to have had 3 arms, to be honest. We wanted to do, 30 days, 15 days, 0. But there is now, but it just wasn't feasible at that time. There is now a study with NIH Recover that's going to look at 15 days versus 25 days or 30 days. So there are going to be studies to look at sort of longer duration.
Another common question, excellent work. Were any immunocompromised patients or cancer survivors included in this random control trial?
I don't have that data off the top of the list. Those were not exclusion criteria, certainly, but probably what may have taken out some of those individuals or if they had drug-drug interactions with Paxlovid. I think it's important to keep in mind that for a small signal-seeking study of about 200 people, it's going to be hard, right, to really assess any of these issues, whether certain subsets will have more or less benefit. But those are great questions and hopefully can be answered in some of the larger studies.
Dr. Wisegas, I may have missed this, but did you check PCR status of patients in the long COVID study? What were the findings?
We did. We collected stool on all individuals, and we did baseline PCR. This was done in collaboration with Dr. Ami Bhatt's group, and those results actually showed that nobody in our study had initial positive PCR from stool. But I think it's important to remember that there are some studies that have shown that sometimes tissue biopsy is what's needed to identify residual virus. So we didn't do that. We just have stool samples.
A question for Dr. Ash. Excellent presentation. Dr. Geng, our site is one of several around the country for disseminating best practices on long COVID. How do we compare and contrast with other sites? I'm hoping to get a more sense. I know your experiences of just running this clinic. I mean, it's a very unique thing you do. But how do we compare to others? What's it like? What's the experiences? Thanks for running this important clinic, by the way.
Yeah, and we're really appreciative of Dr. Ash's team as well, helping us to evaluate and see if our approaches will be effective. And it was really exciting. I just came back from DC from our national meeting, our first in-person kickoff. And I wanted, and maybe it's pre-selected that we're all very similar in many ways. I think many of us are partnering with FQHCs and community clinics, as well as, making sure that we have patient and other stakeholder input. So our models share very similar elements. There's a lot of the peer-to-peer and primary care empowerment that goes into a lot of our approaches. And many others, like University of Colorado, for example, is using an ECHO model, which ours are going to be pretty similar. And so actually with that and learning from each other, we thought about actually at the national level, thinking about, we're all doing this regionally, kind of thinking about how to disseminate. But perhaps at the national level, we should actually just come together. And that's what we're thinking about, making a working group to decide is if we're going to create all these educational materials and try to be able to disseminate in an agile fashion that can adapt to the landscape, should we actually be able to, and we all have different strengths as well, serving different diverse populations in our catchment areas and with our partners. And so, we're thinking also ways to synergize and also and to be most efficient with our efforts as well. So there may be to come a more synchronized and national level of effort to education and peer-to-peer mentoring. Well, we definitely do share a lot of efforts that are similar and models and approaches to peer-to-peer and educational awareness that should be similar. However, there's also unique things. We do serve diverse patient population, like Mount Sinai's population is very different from ours. University of Washington is trying to serve a 5-state region that's going to be very different from ours as well. And so each one brings unique aspects, but we all share some commonalities as well.
Excellent, thank you. Another question from Dr. Naska. Thank you for sharing the pioneering work, Dr. Singh. The Stop Pass trial study population is mostly overweight. How many with metabolic syndrome, if any? Can you comment on BMI, fitness, VO2 max? Is it measured besides physical activity?
Yeah, that's a great question. So we didn't measure VO2 max or others. We looked at patient-reported outcomes in terms of symptoms. So you're right. So about, I think, 60% of individuals were either overweight or obese. It's a small patient population, so it's not clear if that's simply the select group that enrolled. It's also, but there's also data to show that people who either had high BMI or diabetes or other things may end up getting long COVID more. So it's going to be hard to know with our small study, but I think those are good points to see. And certainly in larger studies, I think to look at impact of Paxlovid or other antivirals or other modalities on differential improvement or not in individuals will be important.
As we get closer tonight, I think I like one of these questions Dr. Mosi asks. You're both experts in infectious long COVID, particularly COVID. This question is, what do you feel is most frequently missed opportunities that primary care physicians miss for long COVID patients? Inpatient doctors like myself, all of us, we're dealing with these patients, but what wisdom or expertise might you share with us to help you take care of these patients?
Yeah, I can take this one and start. I think it's so important. I mean, part of what we're doing with the U18 and the REACH program is to try to empower and build resources to help support primary care and partner with primary care. So, a lot of the things are efforts in action, but I think some of the key aspects are, number one, recognition and awareness. And so, and teaching also. Actually, some of the other programs, and as well as ours, I think we should, is think about how we can start to get our trainees involved in thinking about long COVID and be able to, and learn and then and incorporate that into their practices in the long term, especially thinking the broader, as Dr. Singh mentioned, not just long COVID, but the next pandemic, and also other infection-associated chronic illnesses. It's actually not a very well, taught area of medicine and fairly neglected till hopefully now we can shed more light on it. So recognition and awareness. And then, we really need to be able to provide the tools to be able to screen and diagnose, so then people can get to the appropriate care. And we need to be able to build the capacity so that people have the care. But we need to start with education and awareness first.
Thank you so much. I got a couple comments here. Dr. Salas, thank you for the excellent work you're doing. Dr. Georgie mentioned it was impressive that patients took Paxlovid for 15 days, as clinically people stop that way or earlier from the bitter taste. But really a lot of just messages. Thank you for the amazing work you're doing. Thank you for joining us. We'd love to have you back either to share on here, but again, we're happy to share the information when you have it ready for everybody in real time. So please reach out to me if anybody's having questions about updates, and we'll certainly send it out as a press release ASAP if that's okay with you all. Have a great rest of the day, everybody. Thank you so much. Bye-bye.
Thank you. Bye-bye.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.